Dear Honorable Professors, Doctors, and other distinguished guests who are joining in person and virtually, it's my pleasure and honor to welcome you all today to this webinar dedicated to a labor panel discussion on liver miscellaneous. It's our privilege and honor to have you all today. I would like to extend a very well welcome to you and appreciate you are taking time off busy schedule to join us today. We are very glad to see you here. Please allow me to introduce myself. I'm Kyaw Soe. First of all, I would like to read out the agenda before we start. Agenda 1, opening speech by our Honorable Professor Khin. Agenda 2, welcome speech by our Honorable Professor Kyaw Soe Tun. Agenda 3, rare but still possible by Dr. Yen Ao. Agenda 4, where is the enemy by Dr. Wee Phu Lim. Agenda 5, debate is shot by Dr. Joshua. Agenda 6, controlling the giant by Dr. Khin. Agenda 7, acute hepatitis of unknown ideology by Dr. Tu Jo. Agenda 8, closing remark by Professor Khin. According to the agenda, I would like to invite our Honorable Professor Khin to give an opening speech.
Good evening, professors and my dear colleagues. We are quite fortunate to have this kind of academic activity in the sense that this is a kind of a clinical meeting that will give a chance for the people in the district or faraway places or those who cannot come and stay at the hospital to present their views, and we all have a chance to review their presentations, comments on their opinions and comments on their treatment, and that is a very good learning process. For this, I would like to say a big thank you to Mega for sponsoring this. Didn't it? Huh? 11 times this is, and we are, like Professor Tanai said yesterday, our society and our foundation seems to be the only two associations having this kind of active academic activities, including clinical cases and clinical discussions. This is for your survival, and whatever you are treating, whatever you are diagnosing, you need the opinion of other people to comment on the way you think, the way you diagnose, the way you treat. That will be the learning process. All these activities, I must say, are possible mainly due to Professor Kyaw Soe Tun, who is very active, energetic, and leading the way forward for our foundation. And I congratulate Professor Kyaw Soe Tun from here. And I would like to conclude my welcome speech with this, and we'll go on and see the activities, how other people, the presenters will have their interesting cases to be rolled out. Thank you very much.
Thank you very much, CIG, Professor Khin, for my speech. Now, I would like to invite our Honorable Professor Kyaw Soe Tun for welcome speech.
Good evening, CIE and all my colleagues. I would like to welcome you all in person and in virtual colleagues. This is the 11th our panel discussion on liver miscellaneous. The first to 10th meeting is among GLF main and branches all over the country. But SCIG has advised us that we should be sharing more broadly to the other clinicians also. So this is the first time that this liver miscellaneous has been broadened to virtual and in person to all other clinicians also. And thank you, Mega Asomax, for sponsoring all the activities up till 11. And then it will be ongoing for twice to 3 times a year. And I think there are a lot of presentations today because of the limit of time. I have to cancel a few cases. There will be 2 GM presentations and 3 liver presentations today. If I have to tell you some news about our foundation. So our foundation is now doing this what you call guideline. We are writing on guideline on ACC, and it is about to be finished in a few weeks. And then we are starting cirrhosis of liver guideline, hepatitis B guideline, and we are planning for a non-alcoholic fatty liver or metabolically associated cirrhotic liver disease guideline this year. Another good news is we are going to attend Singapore Hepatology Conference as usual. We are aiming to attend more than 50 attendees this year also. So if you are interested in attending the Singapore Hepatology Conference, which will be held on the 3rd week of July at Grand Hyatt in Singapore, you can contact MGLF or Mega One so that we can arrange beforehand. There will be preceptorship as usual, and then if you have any difficulties, MGLF will be very glad to assist you in presenting cases for the preceptorship also. If you had a preceptorship, you have a free, you got almost free for everything except for the lodging and your meals. Without much ado, I would like to hand the floor back to the master of ceremony and then start the clinical section. Thank you very much.
Thank you, CIG, for welcome speech. Now, academic session is starting. Firstly, I would like to invite Dr. Yanni out to present about great but still possible.
Dr. Yanni, and today I would like to present this case. Firstly, I would like to thank CIG and because giving an opportunity for presenting this case. So my data is rare but still possible. So in our clinical settings, there's two programs like diagnostic and therapeutic. So in this particular case, this is the therapeutic intervention for this particular patient. And this is the brief clinical history. So 71 years old gentleman, so he presented with the yellowish coloration of the skin and sclera for 2-week durations. So and he also has inappropriate speech and sleep pattern changes for a 5-day duration. He is a chronic alcoholic. So half bottle to 1 bottle per day for more than 10 years durations. Then last drinks was 2 weeks ago because of he can't tolerate drinking anymore. So there's no relevant past medical history and surgical history, so including the taking the regular taking of the drugs and traditional medicine. On the physical examination, there's a myopia or giguous jaundice. He is confused. GCS is 14/15. San afebrile. Some liver flood is noted, and there's a bulbar hepatomegaly with ascites, and edema is also noted. So this is the initial working diagnostics. Decompensated cirrhosis of liver with the hypertension and hepatic encephalopathy, grade 1-2. So due to the alcohol, is it acute decompensation? So what's the precipitating factors? So management include the nutritional support with the nasogastric tubes, 100 ml per hour, and fluid electrolyte management with the normal saline and hepatic encephalopathy measure, including the rifampicin and evolect and drugs such as antibiotics. This is the initial investigation. And you can see that the WBC is the 29.46. And bilirubin is the 23.2, and the creatinine is the 635. So micromole per liter. So INR is 2.17. So potassium is 555. So HCV antibody is also created. So initial investigation include the chest X-ray and ECG show normal. According to the history, physical examination, and lab investigation. So, according to the ESA scoring, so he has a grade 1-2 HE, hepatitis encephalopathy, and bilirubin is more than 29, that's more than 12, one organ failure, and another one is the renal. So his creatinine is the so high, so 2 organ failure, and that is the ACLF grade 2. With the he has a definitive 2 organ failure with coagulopathy because of the INR is 1.2. INR is 2.17, and the hepatitis encephalopathy. 2 definitive organ failure with the organ dysfunction. So severity assessment at this one is the mass scoring is the 40 point. So mass scoring more than 40 point also noted as a 40. So and mortality is the 71.3% at the 90 days. So and CLIS C ACLF score is the 70 points. Mortality at 1 year is the 97.9%. SOFA score, sequential organ function assessment score, is the 13 point. That's the mortality is the 50 to 60% at the ICU, and CTB scoring. You can see there's so many scoring, but in this scoring for the short-term and long-term prognosis, mass scoring, CLIP scorings, and SOFA score indicate the short-term scoring, and CDB score is the long-term scoring. There is the CTB score is C13, so that is the 50% survival in 1 to 5 years. DF score is 65.5. So here is the clinical problems: HS, EKI, hepatitis encephalopathy, increased bilirubin, and prolonged coagulopathy. So final diagnosis is the EC left with the 2 organ failure due to the decompensation cirrhosis of liver due to severe alcohol hepatitis and XCV infection. So what should we do? Is this EC left or ED? So according to the APAS criteria, acute liver failure include the coagulopathy, INR more than 1.5, and the encephalopathy. And also the mimic ELF defined from the APAS is the mimicking the ELF with the underlying chronic liver disease or cirrhosis of liver. And AD means decompensated cirrhosis got sudden worsening of their condition due to acute events that may present with the hepatic or non-hepatic failure. That's the definition from the APAS. And ESL define the ADs and ACLF very simply like that. In the chronic liver disease, acute decompensation like the ascites or varicose hemorrhage or hepatitis encephalopathy. That means this is the acute decompensation, and worsening of this acute decompensation is the ECLF. So very simple from the ECL definition. So role of liver transplantation in this patient. In this patient, 71-year-old without comorbid ECLF with 2 organ failure, very high SOFA score. So I find so many literature for the liver transplantation in this particular patient. He has 71 years old. So, and the 2 organ failure with the alcohol etiology, there's so many controversy to transplant this patient. And he also has a very high SOFA score. And lastly, the patient can afford the liver transplantation. What's the progress? Creatinine is this is the first time admission, 635. And at that time, we give the albumin with the talipressine 2 mg per 24 hours. Because of the talipressine creatinine response is not good, so we increase the talipressine to up to 4 mg per day. And you can see the creatinine response by 580 in the second days of after admission, after giving the talipressine. And at that time, he got the pulmonary edema. So giving the albumin in the hypoalbumin patient is very common, and it's the more 4 times increase the risk of pulmonary edema, acute pulmonary edema. So we give the bolus dose of furosemide and then stop the albumin. We already give the albumin with the 10 ml per hour. This is a very slow infusion. You can see the potassium. Firstly, he started with the 5.5, and then the potassium is slowly decreasing. So luckily, his renal response, urine output is very good throughout the hospitalization. We replaced with the IV potassium. Hemoglobin dropped after 1 week of admission because of there's a blood oozing from the vessel from the buttock. But there is no GI bleeding. So we supplying the 2 units of blood to hold the hemoglobin more than 9 grams per deciliter. So current recommendation for the albumin admissions and the cirrhosis are the large volume paracentesis, acute kidney injury, hepatorenal syndrome, and spontaneous bacterial peritonitis. In this patient, he has the acute kidney injuries and hepatorenal syndrome. This is a bilirubin trend, and you can see clearly. So bilirubin is very high at the start, and then you can see 10 milligram per deciliter after 1 month duration. This is a creatinine trend without renal replacement therapy. This is a WBC trend of this patient. This is a potassium trend. So he was discharged after 2 weeks of admissions and discharge diagnosis that is due to the decompensated cirrhosis of liver with underlying severe alcohol hepatitis and associated HCV infection. Further plan include the OGD with the very serious screenings, liver measurements to treat for the HCV infection. Progress. So he readmitted again with low-grade fever and limit gates, cellulitis and abscess over the left buttock. So got a history of intramuscular injection at the site. We try and get with the surgeon for incisions and draining of the abscess. This is the liver stiffness measurement. You can see is 54.5. That is the Medavir F4. We done with the OGD, grade 3 varices with the full band of rubber ring was applied. So we treated with the HCV infection with the sulfur and rubber ring for 12 week duration. He got just got the EDR response recently. Current treatment include the non-selective beta blocker, prevention of the HCV measure, and liver support. So current condition is good well-being, gain body weight without edema. This is a bilirubin trend at this present condition. So 0.7. So creatinine is 124. This is a CTP, so progress. Firstly, he started with the C13 and then A6 at the present time. So today, my data is a rare but still possible. He has a rare to survive, but hope a chance to is still possible for this patient. Thanks for kind attention.
Thank you, Dr. Yanlia, for your fruitful presentation, and the floor is open for discussion.
Hello. Say on Timbia Doratema. Agua ACLF go Bjorapon. ACLF is the definition is the biggest problem in the world. Uchanoga Apostle ACLF Research Consortium Nima Tanoa member or faculty. So go to Malome towards the global consensus theme net Dwabi Sunuyama. ACLF a blue pioneers or Shayan Piodare, 2 organ failure. Apasa Gauma Lama Bione. Apasa ACLF lo min piomesoye. Acute compensation about acute compensation and ACLF are totally separate condition. Naku, teacher. To must be the etiology must be hepatic, no hepatic mabao. Septicemia down, shock yellow, varicose bleeding yellow, da ACLF mo, no mo. Edema. Isane ASLD ne at the pet about said the pet. Isane ASLD Isa Blue Biola swing. ACLF a Bama mo decompensated cirrhosis ka the changing acute decompensation when the below now some said da ACLF. ACLF causes tema non-hepatic hypotension no. Biro guna septicemia or sepsis or digabe. Apase alo mo do asha time adiga hepatitis B reactivation adiga. May no hepatic causes labium ne ala ACLF mo. May acute decomposition labium ne. One of the topic I was assigned to review was clear difference between the ACLF and the acute decompensation. Hello, Chini, hello. Hello, Sarah, please note for everybody. ACLF go to a long Mefaldine, Messaldi, or Apasane is a requadro. ACLF, my quenidro, ACLF, ma Loma Sanjimbe. General Macha, really. The theme is towards a global consensus. So, we are Minunku, Diamama, Quemia, and Janabama session women in it through us at the chapel. No? At the chair. Now, for the juniors, alcoholic hepatitis are Meran WVC, Sangan, Nase, those that laser today. One of the sergeants at Janone, WVC 30 is Mayo, Hotakambo, Bosiane, Hoduapo, Tituapo, Lipo. Same result, dear Professor, it is usual for the alcoholic hepatitis to present with the leukocytosis of this amount. Infection is necessary, those are later for the one note lopo. Now, Peter. Oh, the treatment amount, steroid to pentoxifylline note, pure like Genomachala. Rabapilot. Papillo. You know very well the 50% of the cases of alcoholic hepatitis, 50% of mortality, 50% share. All the 90% of the deaths are due to the renal failure because intestinal enos, inos, anos, nitric oxide synthase at enos, inos, inducible, endothelial, neuronal. The area, the genes are upregulated and there is increased nitric oxide the production in the splanchnic circulation. That will lead to splanchnic vasodilatation. That will lead to reduction of the systemic circulation. That will lead to decreased perfusion of the kidney. That lead to renal failure. Whereas era alonga the their chemical the Lara Dopua Penoxifania Lara or Penivella Sivagaro Alupili Shire.
ကြည်ရင်ပြန်စဉ်းစားပါမယ်ဒီမှာ steroid ပေးမယ်မပေးဘူးဆိုတာအဲ့မှာကိုပဲကျွန်တော်ပြန်ရှာကြည့်တဲ့အချိန်မှာ renal failure ရှိနေတာနဲ့နောက်ဒီလောက် severe renal EKI ရှိနေတဲ့ဟာကိုကျွန်တော်မပေးခဲ့ဘူး
Oh, the alcohol hepatitis ma EKI ကိုရှိတာ to reverse that you need to have the steroids. General Homa International Ascites Club ma the steroids, the controversial infection WBC infection and in some cases this is life-saving, no? Force feeding by pentoxifylline, well, you have any why are you so hesitant or reluctant to prescribe pentoxifylline?
pentoxifylline နဲ့ steroid နဲ့ဆိုလို့ရှိရင်တော့ pentoxifylline က role မရှိတော့ဘူးဆိုပြီးပြောလာတဲ့ကျွန်တော်တို့
ဒါပေမဲ့ကောင်းတယ်မပြောတာလည်းအများကြီးပဲရှိသေးတယ်
နောက်ပြီးတော့ကျွန်တော်ဒါလေးကိုပြန်ပြီးတော့ကြည့်တဲ့အချိန်မှာပဲဒါတော့ကျွန်တော်ဟိုဒီလောက်ထိ experience တော့မရှိပါဘူးဒါပေမဲ့ stop age trial မှာသူကပြောထားတာကACLF breakthrough with renal failure solution ဒီဟာကိုပေးဖို့က controversial ဖြစ်နေတော့ပဲပြော
ခုနပြောလို့ ACLF ကိုအဲ့ဒါ grade 1 2 3ခွဲနေတာဒါ easy ဟာအပါဆက်လို့ကိုမလုပ်တော့အဲ့မှာရင် totally ဟိုအယူဆရောအတွေးခေါ် treatment ရောလုံးဝကွဲပြားနေပြီအဲ့လိုရှိတယ်လုံးဝကိုမတူ ACLF ကိုအပါဆက်ယူဆတာနဲ့ easy ယူဆတာနဲ့တခြားသည်အဲ့လို treatment မှာလည်းတခြားသည် grade ခွဲရမှာလည်းတခြားသည်အဲ့လိုဖြစ်နေတယ်If you think that some form of treatment is not harmful and not lethal for a patient, at least for the benefit of doubt, you should try that.
The case matter. I agree with you. General ACLF net light to be show 20 chema. Actually, this is a for the clinicians. You listen to me saying it's a fulminant hepatitis, jaundice and subflopenia. I don't know you haven't mentioned, but I think it's quite near. DF it's a severe alcoholic hepatitis with acute compensation and complications. အဲ့တော့ဒီမှာစီးရလည်းမပေးဘူးเนาะမပေးဘဲနဲ့ဘိရှောက်ကောင်းသွားတယ်ဆိုတော့ဒီမှာဘာကြောင့်ကောင်းသွားတယ်လို့ထင်ပါလဲရတယ်လီဘရေရှင်းကြောင့်လား just 2 year old တယ်မလားစာတာတွေကပဲကောင်းလို့ပဲကောင်းသွားတာလား this is very severe case ကျွန်တော်တို့ဟိုစားပေါ့ liver transplant ထိတောင်စဉ်းစားပြီးတယ် liver transplant မလုပ်နိုင်ဘူးမလုပ်နိုင်ရင်အဲ့မဲ့ treatment က just celebration နဲ့ lasix နဲ့ supportive nutrition နဲ့ကောင်းသွားတယ်ဆိုတော့ why ပေါ့အဲ့ဒါလေ
ဒီမှာတော့ဟောပေါ့မကြည့်အနေနဲ့တော့ early phase မှာဖြစ်တော့ဖြစ်တယ် early phase မှာဖြစ်တယ်လို့ဆိုတာgoal therapeutic window ဒီလိုမျိုးအချိန်မှာ limited ပြီးတယ်လားအဲ့ဒီအချိန်မှာကျွန်တော်တို့က empirical antibiotic therapy ပေးခဲ့တဲ့အတွက်ကြောင့်ဒီဟာကောင်းတယ်လားအဲ့မှာကို systemic inflammation တအားတော့ဆိုးနေတယ်ဒါပေမဲ့ကျွန်တော်ဒီမှာ steroid ကိုတော့ပေးဖို့ blood count ဖြစ်နေတဲ့အတွက်ကြောင့်ကျွန်တော်နောက်တခြားအားတွေနဲ့ကျွန်တော်မပေးခဲ့ဘူးဆိုပေမဲ့တကယ်ဒီမှာကောင်းသွားခဲ့တာတော့ calibration ကိုပဲကျွန်တော်တို့ dose ကိုစပေးတယ် initiate လုပ်ခဲ့တယ်အဲ့ဒါကိုပဲကျွန်တော်တိုးလိုက်တဲ့အချိန်မှာကိုပဲ response လုပ်ပြီးတော့ renal ဒီတော်တော်ပြန်ကောင်းသွားတဲ့အတွက်မှာပါပါတယ် without renal replacement therapy.
Talipressin is nothing to do with the pathogenesis of this alcoholic hepatitis. It will just try to, because of the increased production of the nitric oxide synthase in the splenic circulation, there is splenic vasodilatation and systemic circulation is compromised. So talipressin will make these splenic vessels to contract so that all the blood will flow into the systemic circulation. At the same time, you dilate the systemic, expand the systemic circulation with the albumin. But it is nothing to do with the pathological process of the alcoholic hepatitis.
Okay, Thomas is not amazing. Not a cool labor, alone, albumin pay like boundary edema yares or a lady. I'm Nemaloise general one, toast below below boundary edema yada retimal albumin.
We get it, check out 10 per
hour. How many grams?
50
when the village
20 grams
20 grams or one bottle.
Second,
so do you think this is due to albumin? Or not to check out the case ma yes hepatitis C treatment. Is it wise to use ribavirin in this case in the very early period ma recovery period ma in the ribavirin is it wise to use it? Okay, so with time limit okay, thank you very much. Next presentation. Next presenter will be okay. If you want a discussion, you finish your presentation in 10 minutes. Okay. Okay. Next.
Secondly, I would like to invite Dr. Wei Pioluen to present about what is the enemy.
Rapaisa, please take a seat.
ကြွရောက်လာတဲ့ဆရာကြီးဆရာမကြီးနဲ့ Senior Junior College မှာအားလုံးမင်္ဂလာညနေခင်းပါဒီ Today I would like to present about the case with the title of where is the enemies ဆိုတော့ကျွန်တော်တို့ရှိရတော့ဒီ liver နဲ့ဆိုင်တာပေါ့ကျွန်တော်တို့ဒီ themes နဲ့တူအောင်ကျွန်တော်တို့အခုကတော့ကျွန်တော်တို့ GI နဲ့ပတ်သက်ပြီးတော့ပါပါတယ်ဆိုတော့ let me start with the clinical scenario. My patient was the 63 years old man who was admitted on the December 30, 2022. He has history of the underlying or chronic kidney disease, underlying diabetes and hypertension. And he was admitted for the EVS fistula creation to the hospital. On initial admission, by the sign was an unremarkable, just only that the pedal edema was noted. The initial investigation showed that the anemia HB 9.4 and the urea creatinine is as the U-shaped pattern of the chronic kidney disease, and potassium was 5.6 millimole. So the problem started on that 18 December 2022. The patient present with the bleeding PR about the 700 B, and the patient also suffered from the hypotension with the MAC fella, the blood clots on the diva. So firstly, the renal physician consulted with the surgical team, and then that he was supplying 2 units of the whole blood and other supportive treatment. A proctoscope examination showed the mucosa break with the blood clots at the 11 o'clock position, but no other bleeding on the examination of the proctoscope. So the patient suffered again on the 2 days later, the bleeding PR one time about 300 bead, and then supplying 2 units of the flash whole blood and planning for colonoscopy. But at this stage, the patient, the colonoscopy was postponed due to the unstable of the patient condition. The index colonoscopy was done on the 23rd December 2022, but the scope can be reached only up to the sigmoid colon and cannot advance further. On the return, only just one polyp at the 50 centimeter from the inner part. Again, on 24 December 2022, and the patient suffered again the bleeding PR with the blood clots about 300 ml, and suffer again the hypotension. Hemoglobin dropped down to the 7.8 gram per deciliter, and the supply 1 unit of the whole blood and IV fluid resuscitation. Again, on the 25th December 22, the patient suffered the bleeding PR 3 times again. Blood pressure was 160, and supply 1 unit of whole blood and 2 units of the fresh frozen plasma. Again, on the evening of the 25th December 2022, the patient suffered again the bleeding PR in this time, and was noted the query, the malignancy to the black stool about the 500 ml. The patient showed the MAC fella, so they consulted with me, and so I'm trying to the nothing by more supply 2 unit of Paxil and IV PPI and plan for the OGD and CCD abdomen with the angiography protocol. So let me see about the timeline of the patient condition. The patient was admitted on the 30 December 2022. On the 18 December 2022, the patient suffered the bleeding PR. So they consulted with the surgical team. On the 23rd December 2022, intercolonoscopy was done, just only the polyp was seen. On the 25th December 22, the patient suffered again the bleeding PR and query the malignancy too. So they consulted with me, and I plan to do the OGD and CCD abdomen on the 26th December 22. From this timeline, the patient was transfused about that 11 unit of the blood. So in this slide, we can see clear OGD image. There is no added or blood on the esophagus. There is no gastric varice, or there is no esophageal varice. Duodenum, there is no ulcer. On the CCD abdomen was done on the same day. Just only the equipotent or subtail asymmetry related technique at the sigmoid colon. No detective intraluminal contra-extraposition they appreciated throughout the small and large loops. So what index colonoscopy just only the one poly up to the sigmoid colon. OGD was totally normal. CCD domain showed that no source of the bleeding throughout the small and large bowel. So what about the side of the bleeding? Bleeding, so the index colonoscopy just only the sigmoid colon. So the bleeding soon may be about the sigmoid colon. So and counsel the patient and planning for the second lot colonoscopy on the same day. In this time, colonoscopy reached up to the terminal ileum. We cannot see the site of the bleeding terminal ileum, a sandy transfer colon, and the sandy colon. Just only the ulcer, the sigmoid colon, and biopsy was done. Just only the chronic ulcer. There is no other bleeding from the ulcer side. Then what I see about the poly at the sigmoid colon and trying to remove with the cold-snap polypectomy. So the polycarotenoid, the adenoma polynucleated polypectomy that look like cold-snap polypectomy. The polypectomy, cold-snap polypectomy look like usually are the diameter bleeding go take beyond sewing. But the patient the bleeding risk are securely so we know that the patient presenting with the bleeding and light. So prophylactic hemoclipping was done to the polypectomy size. So the biopsy showed that tubular adenoma with the high-grade dysplasia malignancy cannot be excluded. Show that the index colonoscopy and second look colonoscopy up to the sigmoid, there is no source of the bleeding. So what about where is our enemy? So HA the sigmoid withdraw low line, now we show the retin go out. When the colonoscopy reached up to the retin, I found just only the mucosa break in the retin. Tomorrow, just only the mucosa break. There is no active bleeding on this side. But fortunately for the patient, I put the air bottle on the finger and we do the adequate air insufflation. On adequate air insufflation, the true enemies come out from the mucosa defect, and we can see clearly that there is the vessel stem on the retin. These are the photos of the vascular stent with the mucosa break at the retin. So after finding the enemy, we fight with the hemoglobin. So I deployed to the first side with the first hemoglobin. After the blinding of the first hemoglobin, bleeding was not controlled and started to bleed. So I'm trying to deploy with the second hemoglobin to the same side. After the blinding of the second hemoglobin, bleeding was controlled and I checked with the pushing of the water. So my final diagnosis is Mercer's lower GI bleeding due to the red gelifying lesion. So the gelifying lesion, the gastric gelifying lesion, the stomach here, the greater curvature machine. The gastric gelifying lesion, rubber band PPO, control the patient the massive upper GI bleeding now. So the recheck OGD after 6 weeks of the index gastroscopy mascaring med. The duodenal gelifying lesion. The case are on the say when Zabo comma, the case are the patient the dengue labio, the patient shock anemia nella. Tomorrow dengue young was severe general ranivio. The case could promote scopy medival. Knowledge to bleeding ratio, patient clinical state and Makeda and counseling lobio. She like the chamber. Duodenal, the first gelifying lesion thought people. So I tried to deploy with the duodenal lesion with the combined hemoglobin and adrenal injection to the side. ဒီမှာတော့ကျွန်တော်တို့ကကောင်းတာတခုကတော့ဒီ Judy နဲ့မှကျွန်တော် therapeutic လောက်ရတဲ့အချိန်မှာနည်းနည်းခက်ပါတယ်ခက်တော့ဒီမှာကျွန်တော်ကိုအထောက်အကူပြုသွားတော့ဒီ CAP ပါ CAP assistant endoscopy နဲ့ကျွန်တော်တို့လုပ်လိုက်တဲ့အချိန်မှာဒီ Judy နဲ့မှကျွန်တော်ဒီ scope ကို stabilization ကောင်းစေပါတယ်ဒီ CAP နဲ့ကျွန်တော်တို့အဲ့ဒီမှာ control လုပ်လို့ရပါပဲ CAP နဲ့ဒီ position stabilization လုပ်ပြီးတော့ 3 hemoclip and adrenaline injection was done to the lesion site. Or adrenaline injection to run. So let me continue just only the brief literature review. The July lesion was the distinguished by the French surgeon George Jolofin in the 1898. The term is the Jolofin lesion is also the caliber persistent artery about 1 to 3 millimeter. It accounts for the only 1 to 2% of the acute GI bleeding but recognized due to its rarity. Previous modality before the endoscopy intervention, the mortality was 80%. The major site is the stomach account for the 71% and followed by duodenum at 50% and the rectum was only 2% of the Jolofin lesion. These are the typical patient profile of the patient with the Jolofin lesion. The patient was elderly, multiple comorbid disease, NSCIDs, and the patient present with the MRSA GI bleeding and no previous history of the GI pathologies. So clinical presentation are typically asymptomatic before presenting with the acute severe GI bleeding, rarely present with the chronic occult or GI bleeding, but it also the frequently recurrent and extremely severe less than 72 hours after initial presentation if we don't treat the lesion. The patients are mostly present with the melena and hematemesis. The diagnosis can be done by the endoscopy, angiography, and red cell scanning. Endoscopy, we can see the pigmented protrusion. Initial endoscopy diagnosis just only the 70%. But we need the repeat endoscopy intervention in the 33% and 6% require 3 or more endoscopy intervention. These are the picture of the Jolofin lesion. So angiography is used the one that we can do the colonoscopy or gastroscopy. We can see the non-temporary attached artery at the bleeding site and only extra position is visualized at the erotic pressure at the time of the bleeding. Process scanning is the rarely used and this may permit diagnosis at the lower rate or the active bleeding. A treatment can be categorized that we can do the endoscopy first line and then followed by the angiography and embolization and less resource is the surgery. It depends on the resource available. So endoscopy treatment, there's a multiple modality. We can do the thermic coagulation, regional injection, and magnetic therapy. Angiography and embolization was done in the free endoscopy therapy, lower GI or lesion beyond the reach of the therapeutic endoscopy from the small intestine, who are candidates for the surgery. But angiography and embolization carry the risk of the intestinal ischemia. So we have to consider the risks and benefit of the angiography and embolization. So surgery, the previously and in past history, the first line treatment was the surgery, but now account for the 5% of the case that are refractory to the endoscopy and angiography method. Surgical procedure currently employed include the underrunning of the lesion and wedge resection or the affected section of the cat. The prognosis, the risk of the rebleeding is reported about the 9 to 40%, but the technology in endoscopy is advanced. The increased detection of the Jolofin lesion and mortality rate decreased from the 80% to 8.6%. So let me conclude with my take-home message. Jolofin lesion is uncommon cause of the GI bleeding. It is small. It can be missed, but it can be recognized. but it is treated, we cannot recognize. Second look endoscopy can aid for the diagnosis. We can diagnose it in about the 33% in the second look endoscopy. The adequate amount of the air insufflation is needed to find out the small lesion. The judicious use of the hemostatic device from the available resources is important for the endoscopy. Communication between the clinician is paramount for the better outcome. Thanks for your kind attention. Thank you for your kind attention.
Thank you, Dr. Wipulen, for your fruitful presentation, and the floor is open for discussion.
Thank you, Kyaw Wipulen, for sharing us the rare case presentation, a successfully managed case. The only thing I see as a clinician in Evona, Scopy moving this is a upper lower GI bleeding la below like the less representation merely not on Yanabona. By the 700 cc of bleeding per rectum, fresh bleeding per rectum, patient goes into shock. So there must be some concealed bleeding sheet the lalo, general clinician in essence. Why do you think it is a lower bleeding? There's a learning point for clinicians. How technically. Thank you.
Congratulations, အခုလို second look endoscopy ရဲ့ role နဲ့ rare ဖြစ်ပြီးတော့ traumatic ဖြစ်တဲ့ cause ကို manage လုပ်နိုင်တဲ့အတွက် congratulations ပါအခုတစ်ခုလောက် query ဖြစ်ပြီးတော့မေးစရာရှိတာက rate of blood loss အရာကတော့ vascular လို့ထင်တယ် CT angio မှာက negative ဖြစ်နေတဲ့ reason ဘာဖြစ်လို့ဖြစ်နိုင်လဲဆိုတာရယ်နောက်တစ်ခုကဒီ case မှာrectal က julified lesion လို့သတ်မှတ်လိုက်ရင်သူ့မှာ presentation မလီနာရဲ့ cause ကဘာဖြစ်လို့များအခုနောက်ဆုံး conclude လုပ်လိုက်လဲလို့သိချင်လို့ပါ
Melina တော့သူတို့ဒီ patient reporting outcome ရသူကနေပြော Melina ဆိုပြီးပြောဟို patient reporting outcome ရပေါ့ဒါပေမဲ့ဟိုဒီ patient အဲ့အတွက်လည်း OGD ကသူချိဖြစ်သွားတာပေါ့ဆိုများသောဖြင့်ဒီ first plan နဲ့ဒီ shock နဲ့လာရင်ကျွန်တော်တို့ကဒီခါကျရင် Melina ဖြစ်ချိန်များပဲ upper ကနေထွက်တယ်ဆို all နဲ့ထွက်တယ်ဆိုရင်တော့ဒါမျိုးဖြစ်နိုင်တယ်အဲ့အတွက်ဒီ patient ကို OGD ပါချိလိုက်တာပေါ့ patient နဲ့ Melina ဟိုMelina မဟုတ်ဘဲနဲ့ခံ fresh plan နဲ့ shock နဲ့လာရင်ဒါ upper ကိုလည်း exclude လုပ်လို့များတော့ဖြစ်နေ hematochezia နဲ့လာရင်ဒါ lower ကိုစဉ်းစားဒါပေမဲ့ patient with the shock နဲ့လာရင်တော့ we have to think of the source of the bleeding at the upper GI tract ပေါ့နောက်တစ်ခုကဟို
CT angio မှာ normal ထွက်နေလို့
ရဲ့ limitation တစ်ခုကသူရဲ့ sensitivity is higher at the time of the bleeding so if we do the CT scan and when the bleeding is stopped the sensitivity drop down so ဒါကြောင့်လွတ်သွားလည်းဖြစ်နိုင်တယ်
Xiao Mimo, any comment?
Scope ကြည့်တဲ့အချိန်မှာ bleeding episode မှာကြည့်တာလားသူတို့ interval မှာကြည့်တာလား
bleeding episode ဆိုတော့သူကဟို25မှာသူ bleeding ရတယ်ပေါ့25ဟို25ဒီဆရာတွေ့တဲ့အချိန်မှာ bleeding ရနေလားမရဘူးလား scope ဒီလိုဝင်နေတဲ့အချိန်မှာတော့ bleeding wall ထွက်နေတာမရှိဘူးလား
အဲ့ဆိုကျွန်တော်တို့လည်းဟို surgery တော်တော်များများလုပ်ခဲ့ပါတယ်ကျွန်တော် find ဟို scope finding ကတော့ bleeding ရနေတဲ့အချိန်မှာပဲတွေ့ bleeding interval မှာတော့မတွေ့နိုင်တော့မတွေ့နိုင်ဘူးလို့
ကျွန်တော်လည်းအဲ့လွတ်သွားတော့မှဆရာအဲ့ဒီအချိန်မှာအဲ့ insufficient
Okay, thank you, Ba. Some of my just tomorrow, shall we be Thank you. So, Chenga Doron Jodavi, so that speaker. Please call this that speaker.
Now I would like to invite Dr. Joda to present about the page sweat.
Very good evening, CIE, Bungui, and my colleagues. I'm Dr. Chodar from DSLH. Today I'm going to present a case about the Bay Aswad. That is my patient ID. My patient is 59-year-old gentleman. He has average normal BMI from Kota. And here's a known case of ethanol-related chronic liver disease since 2020, and he took a regular treatment for the CLD and gave up for alcohol at the time. In December 2022, he admitted with the acute decomposition event like the jaundice and the ascites. And in March 2023, next episode of decomposition with the hepatic encephalopathy, HRS-AKI, SPB, and then admit to the Kota Medical Hospital, and then transferred to the private hospital, the Yangon. In June 2023, he went to the Polo hospital, and OGD was done on 6 June 2023. It found to have grade 3 esophageal varices, and EBL was done. And MI also done due to the bad pain. At the time, it's what found to have that post-spine. So an ETB was started on 6 June 2023. And no history of upper GI bleeding, and no surgical history apart from the catheter surgery, and no history of the hepatitis B, C, metabolic syndromes, and other medical comorbidity. And on examination, apart from the jaundice and ascites, there is no remark given. After doing the proper investigation, living donor liver transplant was done on 16 November, October 2023. Intra-op condition was an eventful, and these are 9 units of red blood cell, 3 units of FFP, and 3 units of cryo was supplied during the procedure. After the procedure, he was well tolerated to the procedure and then shifted to the ICU for elective ventilation and correction of his acidosis. Immunosuppressive drug like a steroid, MMF, and tacrolimus was started as per protocol, and then extubated on the post of day 2 after correction of the acidosis. On post of day 3, he developed aggressive behaviors and irrelevant thought, but there is no signs or other neurological diseases. So we hold that tacrolimus for him, and then refer was sorted by the psychiatrist. These are the common causes of other sensorian after the liver transplantation. These are the residual HE in the patient with breast expansion, last continued potassium history of alcohol abuse, donor transmission of the urea, psychiatric disorder, other underlying condition for the hepatic encephalopathy, and central pulmonary myelinolysis caused by the chronic caused by the over rapid correction of the hyponatremia, and another confusion due to the steroid immunosuppressive agent, and diffuse CNS involvement with the meningitis, encephalitis, or focal brain involvement, and another cause is sepsis, warning encephalopathy, metabolic encephalopathy, ischemic strokes, and the intracranial hemorrhage. These are the algorithm for automated stated after the liver transplantation. We should obtain full history, physical examination, laboratory tests, including the blood culture, and then optimize the supportive measure like oxygenation, hemodynamic support, pain management, glucose control, electrolyte balance, and then we must evaluate for the specific etiology like the common offending drug, high ammonia level for hepatic encephalopathy, and focus on the infection outside of the CNS like the targeted culture, infectious serology, radiology, imaging study, and then history of rapid correction of the serum sodium, and neurological diseases of the persistent alteration in the mental state. So my patient has pre-op sodium is 136 and post of day 3 that the current state of the order in post of day 3 sodium was 135, potassium is 3.5, magnesium and calcium is normal, and also ABG parameter is also normal limit, and glucose is also normal. So we plan to do the MRI brain to exclude the breast and central motor myelinosis, and blood culture, urine culture, arterial line culture was done, which show negative, and VRE was positive on the ED tip and right tip. So we tried as the CNS report. On post of day 5, before we doing the MRI procedure, he regained his conscious. So we postponed the MRI procedure, and the tacrolimus was introduced with a low dose. After the post-operative, after that event, there's an event apart from the MIG and something like the nausea and vomiting, and so he was discharged on the post of day 90 with 3 immunosuppressive drug with some liver support. There is the post-op hemoglobin and WBC trend. On the post of day 2, his HP level is less than 7, but there is no active bleeding source at the time, so we transfuse one PRC, and then there is the platelet trend. Pre-op platelets was around 70. After the post of day 9, platelets was increasing trend, show at the graph. And these are the trend for the albumin to bilirubin INR. Albumin was increased after the post of day 3, and total bilirubin INR is high in high pre-operative period, but decreasing trend after the post of day 3 and day 4. There is a liver enzyme trend. ERDA-ASA is highest at the post of day 2, and then downward trend is seen. And for the ALP and gamma GT, it started at the post of day 5 and 6, and then downtrend after the post of day 9. This is the follow-up investigation result after discharge. We do the follow-up 2 week apart and 1 month apart after this event. On 10 December 2023, his AST level and ARD level is quite high with 275, 512. So we get the hydrocortisone. So we assume that there is a mind acute rejection at this period. After giving the hydrocortisone, the next liver enzyme was normalized with the 80s and 75, 57 for AST and ARD. ဒီမှာတော့ကျွန်တော်တို့တက် level ကပုံမှန်အဖြစ်တော့ကျွန်တော်တို့ post op period မှာဆိုတော့ကျွန်တော်8 to 12လောက်ကိုကျွန်တော်တက် level ကိုရအောင်ထားတယ်ပေါ့ဒါပေမဲ့သူ့မှာတော့တက် level ကကြည့်လိုက်မယ်ဆိုလို့ရှိရင်သူ့ရဲ့တက် level ကျွန်တော်တို့လိုချင်တဲ့တက် level ကိုဘယ်တော့မှမရောက်ဘူးမရောက်တော့ကျွန်တော်တို့ဒီမှာတက် limit dose ကိုကျွန်တော်3ကနေပြီးတော့ 3.5 အဲ့ကနေ4တဖြည်းဖြည်းချင်းကျွန်တော်တို့က high dose တွေဆွဲပြီးတင်သွားတော့ 4.5 တိရောက်အောင်တင်တယ်တင်ပေမဲ့လည်းတက် limit level ကလုံးဝလိုချင်တဲ့ target ကိုမရောက်ဘဲနဲ့ခွန်မှာအလွန်ဆုံးပေါ့အဲ့လောက်ဖြစ်နေတယ်ပေါ့အဲ့လောက်ဖြစ်နေတော့တက်ကိုတင်ရင်နဲ့နောက်ဆုံး တက် limit level ကမရောက်ဘဲနဲ့ဘာဖြစ်လာလဲဆိုတော့ဒီမှာကကျွန်တော် creatinine level တွေကစပြီးတက်လာတော့တွေ့ရအဲ့တော့ဒီမှာ creatinine level တွေကလည်းတက်လာတယ်အဲ့နောက်မှာအဲ့ချိန်မှာပြန်ဖောက်လိုက်တဲ့ တက် limit dose ကလည်း 50.9 ပေါ့ဒါဆိုလို့ရှိရင်ကျွန်တော်တို့တွဲထက်ကျော်သွားရဲဆိုတော့ကျွန်တော်တို့ကတက်ကို2ရက်လောက် hold လုပ်တယ်ပြီးလို့ရှိရင်ပြန်ပြီးတော့ short တယ်ပေါ့ဒါပေမဲ့ဒီမှာတော့တက်ကိုတင်ရင်နဲ့ဒါcreatinine level တွေလည်းတက်လာတော့တွေ့ရတယ်ပေါ့အဲ့တော့ဒီမှာတော့တရက်3လပိုင်းတရက်နေမှာဆိုလို့ရှိရင်တော့ကျွန်တော်တို့ဒါတက်ကိုဒီမှာ creatinine level 2.1 ထိရောက်တဲ့အတွက်တော့ကျွန်တော်3ရက်လောက် hold လုပ်လိုက်တယ်3ရက်လောက်ရက်လိုက်တယ်ရက်ပြီးမှကျွန်တော်တို့low dose ကနေပြန်စရပေါ့အဲ့အချိန်မှာပြန်ဖောက်လိုက်တဲ့အချိန်မှာ AST level ကလည်းဒါထောင်ချီနေ ALT level ကလည်းထောင်ချီနေအောင်တွေ့ရတယ်ပေါ့အဲ့တော့ကျွန်တော်တို့ဒါကrejection ဒါမှမဟုတ်လို့ရှိရင် infection ပေါ့ဒါကliver enzyme တက်စေတဲ့ cause တွေကိုကျွန်တော်တို့ဒီမှာစဉ်းစားရတယ်ပေါ့he came back with the abdominal discomfort and the dyspnea of the exertion at the time. There's no chest pain palpitation or the PND. He feel loss of appetite and loss of weight, but there is no fever and cough. Urinary and bowel symptoms are normal at the time. On examination, general condition was every way mind dyspnea with febrile. He has found jaundice was found to have and AND was reduced on the right lower zone. And stony Dana was detected on the right lower zone. So we do the investigation like the CRP height with the 60 and progressive level is normal was 0.24 and CMV DNA was sent it has shown less than 200. It's negative. Chest size ratio right moderate pleural effusion with right upper zone consolidation. Doppler ultrasound was done to exclude the vein and artery occlusion. It showed mild prehepatic collection, fluid collection was noticed, and for the vein, hepatic arteries and hepatic vein flow are good at the time. Urine culture, sputum culture, and blood culture was found to have no organism was seen. SID fluid analyzer was sent at the 4th March 2024. Its appearance was blood-stained appearance and target protein is quite high with 500 milligram per deciliter, but WBC is 2 to 5 say per high power phi. RBC was numerous. There is no AFB and ground stain culture. ADA does not stand at the time. Cytology report show background RBC with aggregated or large ovoid cell appearing dense nuclei. It suggests malignancy. So we do the tumor marker. HOCA 99 was quite high with the 561. BSC and AFE level was normal. Pleural fluid analysis was done on 14 March, but result is pending. So we do the MI abdomen on 30 March. It shows T2 hyperindex loculated fluid collection about 81 May between the pancreatic head and the portal hepatic region. It's most probably myeloma and also found right pleural effusion and minimal SID. So these are the investigation after giving the methylprednisolone 300. So we assume the patient is got acute cellular rejection. So we given the methylprednisolone 300 milligram 3 days with the tapering dose. So AST level, ALD level was reduced after giving the methylprednisolone. And we hold the tacrolimus level, and then creatinine level is decreased up to the normal. So we plan to do the PET scan because malignant cell was detected on the SID fluids and CA1919 was increased. So these are the current diagnosis: acute cellular rejection, disseminated rejection, community acquired pneumonia, which or cough complicated by the right pleural effusion and myeloma. The main issue is increased CA19 level with blood stain, high protein SID fluid. These are our treatment: imidine-prednisolone, acetylcysteine, meropenem, and levoflow, and power liver support. After 30 or methylprednisolone, patient blood sugar level was increased. So we consulted with endocrinologist and giving aciclovir with 2-OAD treatment. So in the era of the tacrolimus, the incidence rejection is dramatically high. Before the era of tacrolimus, rejection rate is about 30 to 60%, but now the rejection rate is around 10 to 20%. But it's not completely harmless drug. A higher attack level can contribute the neuropsychiatric symptom, renal injury, and more prone to infection. But lower attack level can cause the great rejection. So ဒီဟာကိုတင်ရတဲ့အကြောင်းအရာကိုtacrolimusအကြောင်းပေါ့tacrolimusကတော့ဒါကတော့သူ့ရဲ့ level မရောက်တဲ့အချိန်ကိုမရောက်ဘဲနဲ့ပေးထားတယ်ဆိုလို့ရှိရင်လည်းဒါက rejection risk ကတက်လာတာပေါ့သူ့ကိုပေးတဲ့အချိန်မှာဒါက level များသွားတာဒါမှမဟုတ်လို့ရှိရင်tacrolimus ကို dose ကိုများပေးနေတယ်ဒါ prone to infection ဖြစ်နိုင်တယ် renal injury ဖြစ်နိုင်တယ်ပြီးလို့ရှိရင် neuropsychiatric symptom တွေဒီမှာပေါ်လာတယ်ဆိုတာလေးဒါလေးပြချင်တယ်
တခုပါပဲเนาะ case က presentation နဲ့နည်းရှုပ်တွေ့တော့အားလုံးလည်းဘယ်လိုမှလိုက်နိုင်မှာမဟုတ်တခုပါပဲ tacrolimus ကိုညှိနေတယ်ပြောပြီးတော့ tech level ကိုနှစ်ပတ်နေမှဖောက်တယ်ဆိုတော့အဲ့ဒါလေးတကူကနားမလည်နိုင်ကြပေါ့เนาะတက်ကိုပေးတယ်မတက်ဘူးနဲ့ငါ့ဒါမှညှိနေနေ tech level ကို closely monitor ဘာကြောင့်မလုပ်ဘဲနဲ့ 2 weeks မှဖောက်တာလဲအဲ့တော့ဟိုတက်ကိုညှိမယ်ဆိုလို့ရှိရင်ကျွန်တော်တို့က 5 တို့ 5 တို့ကနေပြီးတော့ 5 တို့ရဲ့ 5 တို့တောင်လို့4 တို့ရဲ့ဟ
ဘယ်လိုပဲညှိကြနေတာဒါတော့ဟိုလူနာရဲ့ဟိုတက်နိုင်တဲ့နှုန်းပုံမှာမြည်ပြီးတော့ကျွန်တော်တို့ဟို ARD ASD ကလည်းအရင်တက်မသွားတာဖြစ်တဲ့အတွက်ကြောင့်ကျွန်တော်တို့ကဟို closely monitor မလုပ်ဘဲနဲ့တစ်ပတ်နေမှနှစ်ပတ်နေမှလို့လူနာ OPD visit ပြန်လာတဲ့အချိန်မှာကျွန်တော်ပြန်ဖောက်ပြီးကြည့်တကယ်တော့ဖြစ်လို့မှာဖောက်ပြီးတော့
life endangering case ကိုပတ်စံလေးငဲ့ပြီးတော့မလုပ်ဖြစ်ဘူးဆိုတာတော့ it's not မဖြစ်တယ်ပေါ့နော် okay thank you so let's go on to the fourth case မိရေခဏချိန်မှမယ်ဟိုတယ်လာခဏလေးနဲ့ဒီခံပေးပါ
Now, I would like to invite Dr. Henderson to present about confronting the giants.
Hello. Hello. Good afternoon, CIE professors, seniors, and my colleagues. I am Dr. Henderson, second year Gen Fellow from number 2 Military Hospital. Today is my pleasure to present a case on behalf of our Gen department with the title of Confronting the Giants. My patient is a 60 years old lady from the slum area of Tenganjung Township with the from the low socioeconomic state family. She admitted to our hospital at the last week of January 2024 with the chief complaint of abdominal pain off and on for 7 days duration. 3 days prior to the admission, she presented with the worsening of the upper abdominal pain immediately after lunch. The site is epigastric as well as the paraumbilical origins with the sudden onset, burning as well as colicky in nature, no radiations associated with nausea and vomiting of the meal, intermittent in character, and moderately severe in intensity. There was no reflex symptoms like heartburn, regurgitation, swallowing difficulties, and no history of upper GI bleeding, no history of diarrhea, constipation, abdominal distensions, no features suggestive of habitobiliary symptoms like the fever, jaundice, and RC pain, no features suggestive of ischemic heart disease. Actually, she has history of constitutional symptoms like the loss of weight and loss of appetite for 1 month's duration. Regarding the past medical history, she has history of hospitalization due to the acute severe gastritis and query intestinal obstruction 2 years prior to these admissions. Since then, she admitted that she had been suffering the multiple episodes of abdominal pain and requiring frequent visit to the local clinic. And she has also comorbid with the type 2 diabetes recently diagnosed 8 months ago. no remarkable drug history, and no family history of GI malignancy. For the above symptoms, she had to visit to the local GP, where she was diagnosed on ultrasound as the fatty liver and gastritis, and then treated as the gastritis with the PPI antacids and antispasmodics. Although receiving above treatment, she didn't improve her symptoms and became worsened, so she decided to admit to our hospital. On examination, revealed the mind failure and other by the signs are okay with raised blood sugar level about 223 milligram per deciliters. On abdominal examination, abdomen is soft, mind tender and epigastrian, no guarding rigidity, no mass, no hepatosplenomegaly, and just slightly increased power sounds. So we consider this abdominal pain of this patient probably due to acute and chronic gastritis because she has history of gastritis with hospitalizations and repeated episode of epigastric pain within 2 years. Or this patient may suffer a partial IO because of sudden onset abdominal pain, colic in nature associated with vomiting. Or this patient suffer just the peptic ulcer disease complicated from the chronic gastritis, or due to the malnutrition features and recently diagnosed diabetes and repeated occurring abdominal pain, he probably due to acute and chronic pancreatitis, or we also consider other GI malignancy and poorly controlled diabetics. So we treated her initially IV hydration, IV blood glucose control with the IV insulin, followed by oral hypoglycemic agents with oral PPI, antacids, and anti-emetic and liquid diet. Then we proceed our diagnostic workup. Blood tests will be unremarkable findings apart from little bit raised platelet count and mine increased alkaline phosphatase level. Her amylase and redox tests are also negative. Ultrasound abdomen rechecked on our hospital revealed the just fatty liver and gallbladder slacks, and plain X-ray abdomen also revealed no abnormality detected. Her chest X-ray just revealed the mild cardiomegaly with left basal chest infections. And during the workup of the heart diagnosis on the 3rd day of hospital day, her abdominal pain is still unabated, and she became febrile with symptoms of UTI. So we trying to remove this distinguish this worms with the endoscope. But at the time of worms coming out of the patient mouth, the patient is just under the conscious sedation. She is aware of these worms coming out from her mouth, so she is became restless. And so we postponed the procedure after removing these 2 worms, and then the 2 hours at the evening revealed the acts of the ascaris lumbricoides. Only at the time after endoscopy date, the patient admitted that she has history of vomiting of 2 large adult worms, 2 years ago hospitalizations, and deworming also was done at the time, but we missed this history at the time of this admission. So we can finally conclude that this patient abdominal pain is probably due to the worm colit with ascaris lumbricoides. So we did the deworming with the albendazole 400 milligram for 3 days durations. 3 days after deworming, on reviewing the patients feel something's moving in her abdomen, and she didn't relieve her abdominal pain, although just reduced in frequencies. So we considered to do the second endoscopy and colonoscopy. Here's the second time OGD, really nothing remarkable in the esophagus and stomach. But in the second part of duodenum, we can see the large ascaris worms trying to enter the biliary tree. So we decide to remove these worms by the biopsy forceps. If we didn't do so, the patient may have been suffering from the biliary ascariasis. Here we can see the large worm trying to enter the biliary tree to the ampular vata. On removing these worms, it's a little bit difficult because it is stuck in the biliary tree. So we have been trying a little bit 2 to 3 times. Yes, this time the worms is bigger than the previous 2, which is about 20 centimeter in length. Then we proceed to do the colonoscopy. It reveals nothing remarkable in the proximal colon, but in the distal colon, we can see another live worms moving to and fro in the distal colon. So we try to remove again these worms out of the colon. This time, we can remove 3 worms out of the body, and we remove totally 5 worms with the two-time endoscopy. Then we add mebendazole 500 milligram HS for 1 day. After giving these deworming, the patient abdominal discomfort totally resolved, and she can be discharged with the complete resolution of all symptoms. And at 1 month follow-up visits, the patient reported that she is continued in good health with no recurrence of abdominal pain. She totally kicked out his long-term abdominal pain since then. There's also a case report of ascariasis as a cause of recurrent abdominal pain in the journals. In this case, here's similar to our patients, about 59 years old patients, female patient with the recurrent abdominal pain, presenting with the normal examination findings and no remarkable findings in the investigations. And during the endoscopy, in this case, multiple adult ascaris can be seen in the second portion, and one of them, some of them are staying with the bile, probably due to the entering into the biliary tree, and we can see the bile staying in their gut. In this case, this is due to the ascariasis, biliary ascariasis with the idiopathic pancreatitis case. So the lesson we learned in our case are that the intestinal ascariasis may cause vague symptoms, leading the patients to undergo unnecessary investigations, as well as multiple OPD visits to search for the cause of their recurrent abdominal pain. The intestinal ascariasis should be included in the differential diagnosis of recurrent abdominal pain, particularly in developing country like our country. The diagnosis require the high index of suspicions and can be usually made to the combination of blood counts showing the eosinophilia and stool studies revealing the X. Adults, particularly those with a high-risk lifestyle, may still be susceptible to heavy wound infestations. So simple deworming can alleviate the recurrent long-term abdominal pain without complication like in our case. Health education, personal hygiene, sanitation, and safe water provisions are essential to prevent the continued infestations. To refresh our memory, the ascaris is one of the nematodes, and it is the largest worm of nematode parasites. They are similar to the earthworm, so that's why they are called the Ascaris lambricoides. The epidemiology is worldwide and most numerous in less developed countries, especially in areas with poor sanitation. In the world, about 25% of the world populations are harboring the Ascaris lambricoides, according to the global data 2010. In Myanmar is the 8th highest SH prevalence in the world, with estimated 40 million people are at risk requiring the preventive chemotherapy, according to the WHO data. Here's the 8th highest SH prevalence data. And in Myanmar, in 2002 and 2003, WHO led MOH's parasitological survey was done with the 1,000 children in different schools of the country. At the time, the prevalence of the swine-transmitted helminth infections was about 70% of school-age children. Among them, the Ascaris is the second most common, about 50% of prevalence. According to the life cycle, as you all know, the adult worms pass the feces, eggs in the feces, then they are incubated in the swine and became infected cysts, and then they are swallowed with the swine transmitted method into the fecal oral route. Then they enter the stomach and hatch in the intestine, and then they invade the intestinal mucosas to enter the hepatitis cycles to the lungs. Then they penetrate again the alveolar wall and reaching to the throat, and then they swallow again, and the life cycle restart again. Children are usually acquired by playing in dirt contaminated with ash. Adults are usually infected with the famine or eating raw vegetables from plants fertilized with the untreated sewage. Females worms are more larger than the males, and they can deposit about 200 eggs per day. They can live in the pupil for about 1 year durations. The clinical features usually they present with no symptoms in most patients. Initial infestation will lead to the pulmonary ascariasis in some patients with low flow syndromes. Severe intestinal symptoms may present with the abdominal pain, distension, nausea, and vomiting, especially in large number of mature worms. They can present with a partial or complete small bowel obstruction, especially with the larger number of worms. Fatality cases are usually due to the obstruction, interceptions, and volvulus. The pancreaticobiliary problems can occur due to worms entering the second part biliary tree, resulting in the biliary colic, obstructive jaundice, acynic cholangitis, ecalculous cholecystitis, and acute pancreatitis. They can be diagnosed by blood count showing the eosinophilia. The ascaric eggs can be seen on the stool-RE imaging findings with the variant X-ray ultrasound, revealing the long linear filling defects within the small intestine. And endoscopy can also reveal, in our case, in the ERCP, we can also see the filling defects, linear filling defects in the cholangiogram. So according to the CDC, the treatment of ascaris is albendazole or mebendazole. They are the drug of choice for 1 to 3 days durations. The treatment dose is 400 milligram once daily for albendazole, and mebendazole is 500 milligram once or 100 milligram BD for 3 days duration. Ivermectin is alternative. Then pulmonary ascariasis can be treated with the steroid with 400 milligram dose of albendazole. Intestinal ascariasis with obstruction can be treated with conservative management and surgery. And albendazole obstruction has resolved. Hepatobiliary ascariasis can also be treated like the conservative management. Pancreatic duct and intrapancreatic ascariasis can be treated as just in the case of hepatobiliary ascariasis. And in case of acynic cholangitis, acute obstructive jaundice, and acute pancreatitis case, we may require the emergency.
Will you mind, stepping up your presentation because the time is long overdue.
Thank you for your kind attention.
ပြောနေတဲ့စေနာတွေကတိတ်များနေတော့အကုန်လုံးပြောနေတယ် Ascaris life cycle ပါပါနေတော့နှစ်ခက်ကုန်တော့ဆရာတို့1GH နဲ့ MGH မှာကျွန်တော်နဲ့တက်တူရွယ်သူတာဝန်ထမ်းဆောင်ခဲ့ဘူးလို့လည်းဒီခန်းထဲမှာတယောက်မှမရှိဘူးကျွန်တော်တို့က endoscopy မရှိတော့ during our time we ဘေးရမီကိုအဓိကလောက်ရတာ endoscopy ရှားတယ်ဘေးရမီလောက်မယ်ဆိုရင် radiology department က RE stool RE negative for 3 days ဆိုစာရွက်မပါရင်ဘေးရမီတောင်းလို့မရအဲ့လိုရှိနောက်တစ်ခါတော့ဆရာဦးမြင့်မောင်မေးရမှာပဲ we have the maybe the mythical or the myth Ascaris က pillar track တဲ့ဝင်နောက်ပြန်မဆုတ်ဘူးဒါပေမဲ့ဆရာကြီးမြင်ပြောမဟုတ်ဘူးကဆုတ်တယ်လဲဆုတ်တယ်ပြောတယ်အဲ့တော့ဆရာတော်ခွဲရင်ဒါအများတန်း pillar by like တဲ့မှာသေးနေတဲ့အကောင် calcify 1နေပါလေအများတွေ့နေပါဆရာတွေ့ကြုံလဲ share လုပ်ပါဦး
ဆရာကြီး biliary tree ထဲမှာ ascaris တွေဝင်နေတာကတော့မထူးဆန်းပါဘူးသူရဲ့ life cycle ထဲမှာပဲကျွန်တော်တို့ကလည်းသိပြီးတော့ဒါကြီးကိုအရေးတယူလည်းမရှိပါဘူးနော်ဘာဖြစ်လို့လဲဆိုတော့ natural ပဲကျွန်တော်တို့ဆင်းရဲတဲ့နိုင်ငံဖြစ်တဲ့အတွက်ကြောင့်ဒီຢာတွေကလူတိုင်းမှာရှိနေတာအခုထဲမှာလည်းရှိနေပါပဲဒီຢာကိုတော့အရန်ကြီးအရေးတယူတော့ကျွန်တော်တို့သိမစင်စားပါဘူးအဲ့တော့ဆရာလေးပြောသားတဲ့အထက်မှာကျွန်တော်တခုပဲထောက်ချင်တာabdominal pain နဲ့လာတဲ့လူတွေကိုကျွန်တော်တို့ assess လုပ်တဲ့အချိန်မှာကျွန်တော်တို့ history ရအဓိကပါပြီးရင် physical examination
I would like to request the housekeeping rule. Could you try to be as much as possible to be able to finish in the allotted time?
10 minutes presentation.
Good evening, professors and ladies and gentlemen. I'm Dr. Tutujo, and it's my honor to present in this session. And this is a case of 18-year-old male from Maung, Shan State. He presented with yellowish colorations of skin and sclera for 2 months duration. And he is a grade 11 student, and he was previously healthy. And he suffered from flu-like illness in November 2023, which was last for 3 days with spontaneous recovery. And after that, he developed gradual worsening of yellowish coloration of the skin and sclera. And he also complains of lethargy, fatigue, itchiness of the whole body, and the white color urine. He is a teetotaler, and he denied any drug abuse and over-the-counter medication and herbal medication. There was no history suggestive of hepatic encephalopathy, and there was no bleeding manifestation. On examination, the patient was well alert and orientated. There was deep jaundice with mild pallor, and there was no liver flat, and there was no features of chronic liver insufficiency, and there was no abnormalities on psychiatric and neurological examination, and the abdomen is mildly tender with mild hepatosplenomegaly. And this was the investigation 1 month after the initial episode, which revealed total bilirubins of 30 milligram per deciliter with ALT more than 5 times upper limits of normal, and R factor is 4.5, which is the mixed hepatocellular and cholestatic pattern. And his serology was clear for hepatitis B, C, and retroviral infection. And the ultrasound abdomen revealed findings suggestive of hepatitis and mild splenomegaly. So at this time, the attending physician diagnosed as acute viral hepatitis and gave liver supports. But 1 month later, his total bilirubin rose up to 40.5 milligram per deciliter with indirect bilirubins of 1.3 milligram per deciliter. His hemogram show mild hypochromate microcytic anemia with granulocytosis and lymphopenia, and urea electrolytes and creatinine was normal, and there was normal total and differential counts, and PD and INR was mildly raised. So given the hypochromia microcytic anemia and mild elevations of enteroid bilirubin, we do hemolysis screening, and they're negative for hemolysis. So according to this diagram, if we have persistent moderate elevations of the liver function, we should consider investigation to find out the etiology. So regarding the infection screening, he gave negative for hepatitis A NGM and E NGM. B combo test reveal no features of past infection, and dengue, and SARS-CoV-2 and PCR was negative, but we cannot perform cytomegalovirus, Epstein-Barr, herpes simplex, and adenovirus. Regarding metabolic profile, Kayser-Fisher ring was negative for Wilson disease, and serum celluloplasmin is slightly raised, and the iron study revealed raised ferritin with other normal. The increase in ferritin and serum celluloplasmin might be attributable to inflammatory state. Autoimmune panel is negative for autoimmune liver panel with normal serum IgG level, and there is no abnormality on liver Doppler ultrasound, and MRCP scan also show no abnormal finding. So in this point, we should consider the liver biopsy to get the diagnosis, but after counseling with the patients and his family, they are not willing to do the liver biopsy. So we gave conservative management with a lot of fluids and liver support and closely monitoring. After the next week, the total bilirubin rose up to 45 milligram per deciliter, and there was no downtrend of the liver enzyme. So we started to give the trial of prednisolone with 1 milligram per kg dose after the rule out the infection. So after studies of the prednisolone, the total bilirubin comes to rose down with the downtrend of the liver enzyme. So we give prednisolone for 4 weeks, followed by tapering 1 week by 1 week. This is the serial investigation after prednisolone. We can clearly see the downtrends of the total bilirubins and the liver enzymes. The case here on Bama တွေ့ခဲ့ရတဲ့ case လေးပါအစကတော့ကျွန်တော်တို့ကဒီဟိုဟာဆိုပြီးတော့ acute viral hepatitis ဆိုပြီးတော့ထားတာပေါ့နော်အဲ့ဒါ2လလည်းမကြာ3လလည်းမကြာနဲ့ဆိုတော့ကျွန်တော်တို့ etiology လိုက်ရှာတယ် etiology မှာကျွန်တော်တို့မလုံးနိုင်ခဲ့ရဆိုလို့ကျွန်တော်တို့အဲ့ဒီဟိုဟာ liver biopsy ရဲ့နောက်ပြီးတော့ other virus screening ပေါ့နော်အဲ့ဒါမလုံးနိုင်ခဲ့ဒါပေမဲ့ဒီမှာကျတော့ကျွန်တော်တို့ steroid ပေးလိုက်တော့ response ဖြစ်တယ် response ဖြစ်တော့ကြတော့ဒီချိန်မှာကတော့ etiology အနေနဲ့စဉ်းစားတာကတော့ဒါဟို seronegative autoimmune hepatitis လားနောက်ပြီးတော့ဒီ acute viral hepatitis တွေဝင်ခဲ့တာလားပေါ့နော်ကျွန်တော်တို့ဒီ A နဲ့ E နဲ့စစ်တဲ့အချိန်မှာတော့ဒါ2လကျော်3လရဲရှိနေပြီဆိုတော့တခါလေကြာလို့ရှိရင်လည်းဒီ AE antibody တွေကမတွေ့ဘဲနဲ့များဖြစ်နေလားပေါ့နော်နောက်ပြီးတော့ patient ကကျတော့ဒီ steroid ကို response လုပ်တဲ့အတွက်ကြောင့်မလို့ဒီချိန်မှာရောဒါကျွန်တော်တို့ diagnosis ရဖို့အတွက်ကို liver biopsy ထပ်သွားတင်လာပေါ့နောက်တစ်ခုကကျတော့ကျွန်တော်တို့ဒီချိန်မှာကဟို steroid ကဟို taper လောက်လာပြီ taper လောက်လာတဲ့အချိန်မှာကျွန်တော်တို့ steroid ကိုဒီတိုင်းပဲရက်တင်လာဒါမှမဟုတ်လို့ရှိရင်ဒါကျွန်တော်တို့ဟို steroid sparing agent တွေပေးတင်လာဘာလို့လဲဆိုတော့ကျွန်တော်တို့ဟို seronegative ANH ဖြစ်နေလို့ရှိရင်ဒါကျွန်တော်တို့ steroid ရက်လိုက်တဲ့အခါမှာ flare ရသွားမှာဆိုလို့ Let me proceed to the brief literature review. ဒါတော့ seronegative autoimmune hepatitis ကတော့ seropositive နဲ့ကကြာကျွန်တော်တို့ဟို clinically လည်းအတူတူပဲပြီးတော့ histological features တွေလည်းအတူတူပဲတွေ့ရပါတယ် literature တွေရတော့ဒါကျွန်တော်တို့ 10% of patient with ANH ကကြတော့ဒီ seronegative ဖြစ်ပြီးတော့ဒီIgG ကလည်း normal ပဲဆိုတာတွေ့ရပါတယ်သူကတော့ remission of treatment မှာ remission ရတာကတော့ typical ANH တက်ကိုပိုများတယ်ဆိုပြီးတော့ပြောထားပါတယ်ဒါတော့ကျွန်တော်တို့ဒီ AIH လို့ယူဆလို့ရှိရင်ကျွန်တော်တို့ဒါ seropositive ပဲဖြစ်ဖြစ် seronegative ပဲဖြစ်ဖြစ်နောက်ဆုံးမှာတော့သူဒီ algorithm ရဲ့နောက်ဆုံးမှာတော့ဒါ 3 months corticosteroid trial လေးစပါဆိုပြီးတော့ပြောထားတာဖြစ်ပါတယ်ဒါတော့ AIH ရဲ့ revised criteria ပါနောက်တစ်ခုကကျတော့ဒါအိန္ဒိယ study လေးတစ်ခုပါသူကကျတော့ဒီ hepatitis A နဲ့ E တွေမှာပေါ့ပုံမှန်အဖြစ်ဆိုရင်ဒါ hepatitis A နဲ့ E ကကျတော့ within months မှာကျတော့သူ့ဘာသူ spontaneous recovery ရပါပါတယ်ဒါပေမဲ့ဒီမှာကျတော့ဒီ case လေးမှာဒီ case study မှာကျတော့၄ခုရှိပါတယ်ဒီ၄ခုမှာကျတော့သူကကျတော့ဒီကျွန်တော် patient မှာလို့ပဲဒီ duration ကကျတော့ဒီ2လကျော်လောက်ဖြစ်လာတဲ့အခါမှာသူတို့ corticosteroid ထည့်တယ်ထည့်တဲ့အချိန်မှာပဲဒီ bilirubin ကျလာတယ်ဒါကိုတွေ့ရပါတယ်နောက်တစ်ခုကကျတော့ဒီ cause ချလို့မရတဲ့ cryptogenic hepatitis တွေမှာအဲ့မှာဆိုလဲသူတို့ကဒါ steroid ထည့်တယ်ဒီ case မှာဆိုလဲဒါကျွန်တော်တို့ဒီ AIH အတွက်ကိုအောက်ဆုံးမှာဒီ AIH score လေးလုပ်ပြီးတော့သူကတော့ less than 15ဆိုတော့ဒါ definite မဖြစ်ဘူးပေါ့မဖြစ်တဲ့ patient တွေမှာဆိုလဲသူက steroid ထည့်တယ်steroid ထည့်တဲ့အချိန်မှာဒီ ALT ရော bilirubin ရောဒါ prothrombin time တွေရောအကုန်လုံးကျလာတာကိုတွေ့ရပါတယ် These are my reference and thank you very much for your kind attention.
A very good presentation, but case kind of interesting. The case here, can I not read? Sarah, all markers negative. My cellular negative, pan negative, go negative, so you know. Oh, Bama Bima, then drug induced liver, deliver. Pama Lumuria, Sibius and Google and Bow when you salad out there, as Bawasa, Jay, who do Jona, or item a panina pana in a plus fungal panin, other option. The medication, Maro, steroid response, Pedro, the way you think, the way you treat, the logical process are quite reasonable. Steroid responsive autoimmune or demanding a Piatanaga. Autoimmune panels or autoimmune tests here. Oh, it's very difficult for us to believe everything. Need I run in a Mozambique? Talani Matakala Lode has a Hola, thoroughly young Jiboa Kedel. Anyway, this diagnostic test for steroid. Natakua Samateja is at bring 50 milligram low. Still in to be steroid group still of low lipo. Anyway, thank you very much.
Okay, cryptogenic hepatitis one. I mean, demand the check label by my steroid pyramid. Hepatitis B, surface antigen negative, so you can rule out hepatitis B, but no steroid pyramid, so now the B the chale is excludable. Thank you.
Thank you, our honorable professor, Professor Kemawe, Professor Kyaw Soe Tun, and Mama Matauda Painsa. Now is the time for the closing. So I would like to invite Professor Kemawe to give the closing remark.
Very good case scenario sessions for Dinyama lesson, the way you should learn whenever you're going to present. A very good recent references to Bahama. Hi, Maji, Timajao, Dabjolo. Dia, Dama Peu, Dajao, Diapira, Dajao. Bema International Meeting in my gene reference car at Tepe. All my reference shape army. Pabira Guna Wamso on the Escaris life cycle there, Pura, the Nene Seven Laraguna, Yasibina extraction low lady. Paluhali are 2 days for UAB present over. That the way you should learn about your presentation. Say when I'm here, 2 Jan now so more Piteha, a little UAB will present like we do and must time yourself. Go change Kaibirot, Kadipura 7 Dwema. Limit low be pure now, but pure nine Lucian, Nanganyaga presented ASL was a Bumi to Sotonomy. Oh my God, 3 minutes presentations, 2-minute discussion. How many people at the cool? How many people? General Amnia, let you know, but we since Hippocrates times literature review Thank you. I would like to express my sincere thanks to Medical Superintendent, House Sergeant, Matron, Sister, Waka Blue Staff, Kuni Pere, Alokamagon, Blue Banya, Throw. Yani shade of you. Collagen recently, Quagoli, pure, Tali of Piogenet, Telulume, Tapiomen, Tama. Teluli, Quago Deluri Pioni, you need him, oh, Diani Tetwama, Qua. International the Majamek di Lamene December Mono and then Linelo international speaker Piora Piatora Linelo Piatora December Bovijo Uzibi Loma Piana Biswabi Lomesro. To me, I believe I do not agree with that. Mama ya MMA Mandrubio. Who are pure to Alamo to could be Mrs. Code. Well, I really appreciate your concern. However, we have taken all these steps to safeguard the Banya. Allo PB at Alip Sitorali. Who are pure Sura Alali Le. Good level Mako, Timarin Binebo Mobu, International Tona Muswin, the lady, Pio So, Argue Lome, Nieme Come, Aloli. Tali Tadima. Miamia ten, Miamia Pio, Miamia ten, Dilo meeting o Megalasi a 2 years de mare, they are people not only the lower low oh 2 go a George she de session lady ba. The genius Lulemia easy pure a colonel, Tario the Bob out of Biro. Case you lamb, case it the baby 7 lady, Pobala lady. Molecular pathogenesis para lady literature review ma case I say when I will go on lady we look comment mare. I think I would like to request a few words.
Thank you, Ajay. Mega Jejumai Tamare, Mega 2. And this is a good platform for practice for postgraduate students. And postgraduate also doctorate students. This is a good practice. Lojuza de Nyanda de Jesu de Mai. As I build I'll emphasize not a clinical sign and symptoms, say clinical pirane, you must have a differential diagnosis. A gone below Bajam Bartines or Halidi go, pure piro, 12 below your clinical acumen put tell. Sami Mono general letter on general clinical never low clinical decision. The good decision may be the sign and symptoms, sign and symptoms about investigate on base low tesura, early practice low tap, or technical chaos or colon low chala biroma, diagnosis go you run the low pin in our so early and it is not the right medical practice partner. Rally to check out your money. Now you're gonna build me dyspepsia ne alarm symptoms la bi ro sei yong yaw bi develop ne ma OGD ကြီးဖြစ်တယ်ဆိုတော့အဲ့ဒါလေးကတော့ your OGD policy လေးပြန်ပြီးပြင်သင့်တာပေါ့နော် Okay အဲ့ဒါလေးပါပဲဘလို့နောက်တစ်ယောက်အားပေးကြတဲ့ Seven Liver နဲ့ GI7 ကြားကြတဲ့နော်ကျွန်တော် our colleagues တွေနဲ့ online မှာရှိတဲ့ colleagues တွေအားလုံးကျေးဇူးများတင်ပါတယ်ဆရာပြောသလိုပဲဆက်ပြီးတော့နော်ဒါမျိုးလေးတွေဆက်ကြိုးစားပြီးလှုပ်ဆောင်သွားကြပါမယ် I am practice made perfect ပေါ့နော် Thank you very much. Okay, have a good dinner. Thank you.
We have now came to the end of the webinar, so I would like to say thank you to our honorable professors, doctors, and all of our attendees for joining this webinar today. On our webinar has been successfully finished. Thank you very much.